Hello, everyone. Thank you for coming to the breakout. I feel like the parent perspective is always, no pun intended, the heart, right? Because it's our children that we're speaking of. And so it's been enlightening and really my privilege and honor to be able to speak about some of the things that I've had to remain silent on for so long in regards to being the parent of a medically fragile child and a very complex one at that, as you guys have heard a little bit of our history. And just to kind of recap, Avery Grace was born a little over 4 years ago, and I knew in utero that she had hypoplastic left heart syndrome. We also knew that we had a tricuspid valve issue, and I'm a researcher, if you can't tell. And so I knew what that would eventually lead to. And several hospital stays, we've spent probably about 18 months in the hospital of her 4-year life. And so some of the neurodevelopmental things that we spoke of, we are familiar with that aside from just her medical history. So really, while navigating all of that, it would put any parent in a state of what I now realize is CTSD, because it's chronic, because it's lifelong. It's not just PTSD, but when you add the racial trauma that I've had to deal with on top of that, it's just been a little bit difficult. And racial trauma is not having anyone to relate to the aspect of being a Black woman and being a Black mom, and all of the little adjustments that I've had to make along the way in order to truly advocate for my daughter. And as I mentioned, being seen, being heard, being understood, etc. So that's where I'm at today. Just really happy to be able to share, happy to be able to really start to approach equity within the hospital unit setting, not just for the parents, but for the children, so that we can address these outcomes.
I'm going to start out with our first question, if you don't mind.
Yeah.
Okay. How do you move past tokenism, including transitioning our diversity inclusion efforts into equity?
Everybody's got a program, like I like to say. Everyone says, and they lean on that program. I've got a D&I person. I've got a program. We did an implicit association test, and we do that once a year, and we all came away and our eyes were opened, and then what happened? And so I think that we move away from tokenism by hiring diverse staff, by making an effort to have complete programs and not just experiences. And when I say diverse staff, it's not just one individual or two, hence the tokenism, but making a really complex staff, especially, in places that are urban environments. There's really no excuse or reason why you can't be more representative of your environment if you make it an effort. And so I think that you don't just lean on the name, but you actually, one, now that you know that there is an issue, after you take these implicit association tests, well, what are the follow-up steps? And how are you training your staff? And is there a survey? And are patients asked to answer questions? I get surveys all the time from our institution. Are patients asked to answer questions around racial disparity or their experience, or to see if they felt seen or heard or understood? And then some of those other things that I mentioned, in my talk, as I was kind of thinking through the thing that I've tried to be for other patients, and that I've had the two Black attendings and doctors kind of like step in and be for me. How can we take that off of their plate? And how can we take that off of me, just a person who saw that a difference needed to be made's plate, and put it on to staff? Where's the patient experience person, the patient relations person, the social work? And so I really think it's taking an eye and then taking the steps, because I know that we've all got the eye and we've all got the person, but are we all following the steps within our programs? And I don't think that that's happening right now.
Thank you, Tawanna. And we actually have a polling question for the participants who are on the call. So we'll go ahead and pull that up now. And that question is, racial and ethnic equity is represented in my organization's leadership. This racial equity extends to entry and mid-level clinicians and staff. Okay, and so the results show that 75% of you all would say that this is false for your organization, and we had 25% of you say that this is true and representative of your organization. So we had a little bit more than half of you respond. So thank you for being transparent in your responses. Tawanna, do you have any additional comments regarding this question?
Just sadly that I'm surprised, I think would be the biggest takeaway. But, you know, there was a question of whether we should make these polls black and white, or whether we should say, you know, give more allowance for it, right? Like strongly agree, disagree, etc. And I went for the black and white to highlight the disparity that exists. And so for those of you that are a part of the 25%, that's amazing. The next step I would say is, what are you doing with that 25%? Are there programs for those people to feel comfortable, not just the patients, but the staff as well, right? And for the 75% where that's not the case, we need to start looking at the whys of that. Is it because we're in a rural location and, you know, maybe the diversity just isn't there, in which case you would have to work a little bit harder to recruit out. But if you're in a city or close to a city and it's easier, I think we really need to look at the why, so that we can then take the steps to make it different. Maybe it wasn't a priority prior to everything being brought to the forefront this year, but now that it is, and people like myself are speaking up, and, you know, we've got everyone coming to share the narrative. Now that we know what the narrative is, are we willing to do anything about it? And that does start with that representation. It would make a huge difference to have more people that looked like all of the patients rather than just a few of the patients.
There's a question that has come in from Haley. Does Haley want to ask this, or would you like for me to read it? Okay, I'm going to go ahead and read it. She's the mother of a CHD baby that sadly passed away at 9 weeks of age. When she had a meeting to discuss his death, she was told she was clever and articulate. Why did they not think I was clever when I told them that something was wrong with my son? They ignored my husband on multiple occasions. Why couldn't they not see my intelligence before he died? What can I do to make change happen? Where do I start?
Oh, Halima, that hits close to home, because I've almost lost my daughter more times, and that's nothing compared to the loss that you experienced. And so first and foremost, I just want to tell you, you know, my heart's with you. I can't say that I understand. I don't. I've come close to understanding, but my heart is with you, and I'm so, so sorry for the loss of your child. And I think you've got to be a thorn in their side. to be frank, you have to speak and speak and speak again. Like I said, 3 different people, the same exact question. Took the most common answer, or if I got 3 different answers, then I'd ask the question of the next person. I didn't just listen to the attending that was on duty. I fostered relationships with, you know, different attendings, with different fellows, with different nursing staff. I developed a team for my child. When I say advocating is a full-time job, and then on top of that, kind of trying to overcome the race disparities, a full-time job, they're 2 full-time jobs on top of actually being a parent, and then if you're a spouse or whoever. And so it's nothing to do with you and everything to do with their failure in regards to letting your voice be a heard voice at rounds throughout the process. You know, you are the parent, and so you know your child, and you've got to be confident that you know your child. And all of the education and all the degrees that the clinicians have that give them the ability to care for their life, that's the body, right? They know how to care for the body. They don't know all of the intricacies of your child. And so thankfully at my center, while we did not have a diverse team, we did have a team who would take what I said into consideration in regards to, you're the mom, you know your baby, you know your baby. And I think that your child was so young when he passed away that perhaps there wasn't enough time for you to establish that baseline. Perhaps there wasn't enough time for you to come out of the fog. I am blessed in the sense that I got long enough with my child that I got better and better with each hospital stay. And by the last hospital stay, you know, I was kind of a pro at it, as much as one can be as you ride the ebbs and flows. And so I think knowing from the beginning that you have a voice and your voice matters, and to just be a thorn in their side are the only things that you as the parent can do. The rest is up to them to do. And never be afraid to seek second and third and fourth opinions. Again, love my center, did a lot of research. My daughter was in a couple different spots that weren't so great. Maybe that our center was not the best one for her in that particular circumstance. And so that's what I would advocate for, is never be afraid to get second and third and fourth opinions. And your center should encourage that and should want you to do that, because if they can't help you, then they know that there could be someone who can, or not, but you never know until you try. And again, I'm so sorry, Halima, for your loss, and thank you for your question, but be a thorn in their side, and you use your voice, and you never doubt that you know your child better than anyone, because that's your child.
Thank you, Tawanna. We have a second question from the chat box from Stephanie Nightingale. I'm a heart mom and participate on a few patient family advisory councils, and one of our aims is to help reach minority groups. However, we struggle with having equal representation in our parent group. How do you suggest we reach out to minority parents or lower socioeconomic groups to participate in improving education and patient outcomes?
Great question. I think that we don't feel sometimes, especially if you are a minority and you are in a lower socioeconomic status, you don't feel equal because life has made you not feel equal. And so because life has made you not feel equal, you get accustomed to that mindset, and you don't know the differences that you can make. You don't know that there is anything that you can do. I speak a lot about your voice. Some people don't know that they have the power of their own voice, or when they utilize it, because they don't exactly get the terminology or, what have you. Maybe they feel like they're being condescended or spoken down to or not understood. And so then people tend to clam up because they don't feel that it's a safe space. They don't feel comfortable. And that doesn't lead to advocacy, right? If you're going to be an advocate, you have to be able to be in relationship with others that look like you, don't look like you. And maybe that's not what they're accustomed to. I live in Chicago, and it's a very, very diverse, but very segregated place. And I'm from New York, where I'm used to everyone being together. And so it amazes me here how people don't intersect. And so when people aren't intersecting, from a Caucasian perspective and from a Black perspective, then you don't know how to speak to one another and interact with one another. I've dealt with more ignorance here racially than I did when I was in the Northeast. And so I would say, you've got to get somebody that looks like them to reach out to them, just to put them at ease, even if it's a false sense of comfort to begin with, right? You've got to get someone, my experience is not Lauren's experience, which may not be someone else's experience, but there will be some intersection, some commonality in that experience. And just by the color of our skin, like I said, if I had seen more representation at my hospital, I would have felt like I could breathe a little bit more, just knowing all of the things that I personally know about the disparities in healthcare and wanting to make sure my daughter didn't become an effect of that. But so you need to get somebody that looks like them. And then you need to teach them how to use their voice. You need to teach them that they have a voice, and you need to get them up to speed in layman's language of everything about, the defects or about the organization. The educational aspect might not be the same, but it doesn't mean that they don't have the ability to understand. We just have to meet them where they're at. And I think when you do those things, and I'm a big part of the Children's Heart Foundation, there's not a lot of people that look like me. There just aren't, right? Across the country, but especially not in Illinois. And so I understand the need for that. But I do understand that if I am the ambassador and I go out and reach out to those people, I might have a better outcome, at least at this point in time, especially with everything so racially charged, than a Caucasian person would.
Thank you, Tawanna. And Sarah has brought up a good point in the chat. She said, how might that engagement look differently for mothers versus fathers?
Men don't like to speak up all of the time, there's a really good, strong heart mom community. Not the same for heart dads. And I don't know if it's because the moms maybe percentage wise tend to be, it's your child and maybe you're physically there more, or whatever the dynamic is, or maybe because I sought connection at the beginning, whereas my husband kind of bottled it all in because he felt as if he had to be the strong one, and ultimately what we found out, and he'll kill me, is that I handle the crises and these things better than he does, right? But I also am more emotive about it and accept my feelings as they come. And so I think that we've got to create programs specifically for heart dads. There aren't a lot of them. And I think we need to meet them where they're at and get them comfortable where they're at. And so it might be something around sports, it might be Top Golf. It might be just things that are, just not as feel good. My husband loves the walks, right? He doesn't want to be in the walk committee though, and a lot of times it does become woman centric. So I think creating spaces that are specifically for heart dads and meeting them where they're at to facilitate whatever kind of conversation they'll have or not is what we need to do.
I think you're also better at communication. The heart moms are better at communication and understanding and just kind of going with it.
Yeah.
And knowing what to ask. And it takes the dads a little bit longer. So
yeah.
I'm sure that can feed into that a little bit.
So we've got another poll question for you. Racial and ethnic equity is represented in my organization's engagement of patients and families to inform quality of life, process, and outcomes work. And it looks like we've got about 60% of you all have voted. So we'll go ahead and show the results. So about 74% of you all said false, and 26% of you all said true. So once again, about the same breakdown as the previous poll. Any surprises here for you, Tawanna?
No, unfortunately not.
Yeah. I think that there's a really great question in the chat, and a good way that we can really kind of transition to wrapping up our breakout. What can organizations do to recruit and include Blacks, Latinos, Hispanics, Asian subpopulations in our QI work? And what tools can you suggest that providers and parents can use to pursue the dialogue, for example, on rounds? And thank you to Martha Clabby for that question.
So I'm fortunate in that I have a mind that I'm not a clinician, but at some point people started asking me if I was all of the time because of, what I'm able to know and retain. I think really, sometimes there is an APN or someone who comes in before a surgery will kind of give you like the breakdown, and they'll bring, a dialogue and a book, and they'll kind of like tell you. I think even that sometimes is a little bit much for some patients. And so it's hard to speak on what you don't understand. There are patients whose parents I speak to and they don't know how to pronounce their child's diagnosis. Where do you go from there if they don't know what they have and they say, oh, I just trust the doctors? And of course you have to trust your team after you vet them. but you trust your team, and when you trust your team implicitly, again, you know your child better than anyone else, and you have an intuition and you have an instinct, most of us do, about our child. And so you have to at least be able to feel comfortable speaking up on those things until you get the clinical part. And I think we need to have weekly check-ins about, did you understand what's going on? And have someone break it down in very, very layman basics terms about what's going on, and have them reiterate it. My daughter, after she had a transplant, we had a quiz, right? And I had to get like whatever grade on the quiz before I could be discharged with her. Some of those things, while it could be intimidating to someone, just make sure, maybe they're not a test person, but make sure they know why they're doing what they're doing, how to care for their child. Make sure that they know in layman's terms those basic answers, so that then they'll feel empowered, and let them know that their voice can be heard. A lot of times it's harried, or it's varied times of the day, or there might be complications or whatever. And it's like, any questions, mom? Any questions, dad? And they're just like mind blown. But if we could have someone double back later on, or a couple of times a week, just to make sure, well, do you understand what's going on and why this is problematic or how this would be helpful? I think that would be a huge help, because when you have an understanding, knowledge is power, knowledge is confidence, knowledge helps you use your voice, knowledge, will really, really make a difference in how people are able to speak or not speak, to care or not care. And when they're discharged, what will happen, right? What happens when they're discharged? There are patients that I know for a fact have been kept in the hospital for months and months because their parents are not equipped to take care of them. And that shouldn't happen, because we need those beds, and that's not the best way either, right? And so I think we just need to take a step back from the clinical side of it to see what each family needs. And I think that shouldn't always be the clinician's responsibility, because you're there for the clinical care. We need to have someone else that is a liaison between you and the family.
Yeah, and you're absolutely right about that. And there's another question from Gwen. We see a fair amount of parent-to-parent and support in social media groups, especially on Facebook. Yet those involved do not appear to be racially diverse. Do you have any suggestions for increasing more diverse engagement in those resources?
You know, I don't think that this just shows the disparity. And it shows the disparity in who's being reached out to, right? They don't know that these things exist. They don't know about CHF, or if they do, they don't understand, literally do not understand how fundraising for research will help improve the outcome of their child's life. It's not an immediate kind of thing. It's a kick, you know, just kick the ball down the street a little bit kind of a thing. So they're not going to be involved in that. They don't know about conquering CHD. They literally do not know. They don't know that there's support. They may not be comfortable with seeking support. That's the other thing. You know, I can speak from my Black experience and say that, you know, reaching out, like there's stigma in mental health, and there's stigma in going to the doctor, and there's all these stigmas, and there's stigmas in letting like outside people or family, you know, the outside of the family know your business, so to speak, to, you know, to put it in kind of like blunt terms. And so they might not feel comfortable sharing. But really, when I come across minority families, it's because they don't know about these programs. And so even if they get the Conquering CHD owl basket, whatever it is, you know, at the time, maybe it just gets overlooked, and maybe they use the sanitizer and the pen and get the coloring book or whatever, and then they throw it to the side. There's not real follow-up. And so if they knew that those groups existed, and if they felt comfortable, you know, sharing their story, getting support, being a part of something, then I think that we would see the difference. But you've got to reach them first, and they're not being reached.
Thank you. We've got one final poll. My organization provides annual cultural competencies training for clinicians and staff. Okay, we have about 60% of you have voted. And so 61% of you have said false. A little bit larger with this poll, 39% have said true. So it does look, at least with some of our participants, that the cultural competency training is taking place, which is encouraging. It still seems as if there's some opportunities, though, within a few organizations. Are there any additional thoughts that you would like to share, Tawanna, as it relates to the polling questions? Or participants, do you have any questions that you want to ask Tawanna specifically? We do have another question in the chat. Tawanna, do you have any recommendations on how nurses like myself can further support congenital heart disease minority families? And that's from Austin Lane.
Austin, that is fantastic. Thank you for that question. Just because the nurse is, I want to say everything. Kudos goes out to nurses, right? But the nurses are your day-to-day. And a good nurse, or a nurse that maybe isn't as trained or isn't as responsive or isn't as open to parent assistance and understanding that a parent is a team member, right, can make all the difference in the quality of days and the quality of stay and the quality of care. And so, you know, speaking from my own personal experience, again, 2 nurses of Black descent within all of the different hospitals that I've stayed at. And one, I was like surprised, like I didn't know that there were any, right? Like when someone was like, oh yeah, you know, there's this person, and I didn't know that there were any. Conversely, there were nurses who were clearly had not been raised or exposed to diverse people. And so the nurses brought stereotypes and biases to the care. You could see that in some of the things that were said. You could see that in, you know, the way one family was, you know, treated versus another. I am very, very perceptive. And I'm very detail oriented. And so I notice everything. And again, it happened to me, but it more happened to, let's say, the 20-year-old mom with the HLHS child who, you know, didn't dress up for a round and was present or, you know, wasn't present or whatever. And so I say the one thing is to really work on that implicit bias training, because if it's not going to be as diverse, the staff, and that's not something that can happen overnight, right? And it's not something that's largely up to you as a nurse. It's really kind of like checking that at the door and making sure that a lot of those biases are unconscious, but making sure that you try and learn about them and are aware of them and let that translate into your care. And then if you have some extra time, some of that liaison between, you know, the clinician or the attending or even the fellow that I was speaking of to the family, I think making sure that they understand, you know, if you have extra time in your day, if it's a slower shift, or if maybe, you know, the child's intubated, or, you know, whatever the case, if you have more patient interaction with the parent and the family, speaking to them and really making sure that they have an idea and helping them know what their power is, right? Because the doctors, the attendings, the fellows, they come and then they go. They come and then they go. You as the nurse, you are the solid. You can determine the day. Every day. There was this, I didn't have a team yet, and I was advocating for a team, and it was a really big deal because I like for people to know my child and to know our family. And we had 20 different nurses within, I don't know, like it's 7 days. It was like people changing over shifts, and I just got really, really frustrated. And I heard some comments that I didn't like, and I was like, okay, this, you know, I'm speaking up about this. This has to stop. Making sure that there's continuity of care as well is huge. So continuity of care, checking your implicit biases at the door, and making sure you take the onus, you know, part of the onus, not all of it. It's not all on you, but just really helping the parent understand, you have this question, I explained this to you, ask that in rounds. Rounds are going to be this time, Mom. Go and get your coffee, but make sure you're back because I think they're coming around this time. And I want you to ask that question because as the nurse, you can then help the clinicians and the providers and the attendings and the fellows see that parent as someone who is advocating for their child and interested, has a voice, has a say, and should be heard. Great question, Austin. Thank you.
Thank you so much, Tawanna. We have went ahead and we have put the registration link back into the chat to head back to the main session. They're wrapping up there. So we want to appreciate you, Tawanna, for taking your time out, for being courageous, for sharing your voice, for giving us strategies to really make sure that Blacks, that families that are you know, from racial and ethnic minorities, that their voice are included in this journey. So thank you.
Thank you all.